Thank you, Mr. Chair and colleagues. I'm pleased to present the AHEAD Act, AB 1726, Accounting for Health and Education in API Demographics Act. This bill will reveal health and education disparities of ethnic subgroups in the API community that will provide a deeper understanding of the challenges our communities face and better prepare us to face those challenges. California is home to the nation's largest Asian American and second largest Native Hawaiian and Pacific Islander populations. Each of our diverse communities are different, have unique experiences, and instead of using a monolithic other Asian category, it's important to make sure that we have the experiences of API subgroups appropriately captured. We do this now. Make no mistake, this is done at the federal level, this is done at the state level, but at the state level, it is not complete in terms of our data collection. And by adding a few more categories as set forth in the bill, we think that we can create a better set of data that can help inform any additional steps that we might want to take based on the data. I have with me today Kimberly Chen with the California Pan-Ethnic Health Network and Calvin Chang with Empowering Pacific Islander Communities to testify in support.
Good afternoon, and please proceed.
Mr. Chair, members, Kimberly Chen with the California Pan-Ethnic Health Network, proud to be a co-sponsor of AB 1726. As Assemblymember Bonta noted, our communities share a tremendous amount of similarities, but also have differences that can have significant impacts on health outcome. And without the collection and reporting of state data on the smaller Asian, Pacific American, and Pacific Islander groups, there are needs that are overlooked or underestimated. For example, overall, about 20% of Asian American children in the U.S. are overweight, but when we look at the disaggregated Asian groups, Filipinos and Southeast Asians, including Indonesian, Malaysian, and Thai, have significantly higher prevalence of overweight children. This data is helpful in identifying disparities and developing targeted strategies to address their underlying causes, finding out why these children might have higher rates and how we can better address their needs and develop strategies around that. In another example, looking at cancer incidence and mortality data among Asian and Pacific Islanders, the overall cancer incidence rates for Native Hawaiian Pacific Islander men is lower than that of non-Hispanic white men. However, if you look at cancer mortality rates, those were higher for Samoan and Native Hawaiian men than the non-Hispanic white men. So there is a tremendous disparity between the incidence and mortality rates. So having this data is incredibly valuable in identifying specific health conditions and outcomes and developing targeted and perhaps in language or culturally appropriate educational materials for these diverse populations. I'll conclude with an example of how this has worked at the local level. Some folks may be familiar with Asian Health Services in Alameda. It's a federally qualified health center that provides medical, behavioral, and dental care to over 25,000 patients in English and 12 Asian languages. The health center smoking cessation intervention programs have been incredibly successful at targeting Vietnamese and Korean men because the analysis of disaggregated data showed that they have some of the highest smoking rates. With aggregated data, we wouldn't have seen that, and they wouldn't have been able to develop such specific targeting specifically for folks who may be limited English proficient. This also is very important for types of interpreters that the center has hired. For example, in 2010, when they started seeing an increase of Burmese patients, they were able to hire more Burmese interpreters. This is also true when they saw an influx of Mongolian patients and hired Mongolian staff. They were only able to identify these needs because they collected disaggregated data. We already collect much of this information in DHCS. Department of Healthcare Services has up to has a number of API languages within its threshold languages. So collection of API subgroups to target needs and target specific educational outreach is something that we already do. We're only expanding this to include some of the more granular categories. This bill will help us better direct our resources and drive research. And for these reasons, CPEN is in strong support and urges your aye vote.
Thank you. Anyone else in support?
Aloha Kaku. Good afternoon, Chairman and members of the Senate Health Committee. I'm Calvin Chang, and I'm here on behalf of Empowering Pacific Islander Communities in strong support of AB 1726. My organization serves the Native Hawaiian and Pacific Islander community in California, which is one of the fastest growing racial groups in the state and consists of over 20 distinct Islander groups, each with their own distinct language, culture, and traditions. My organization, in partnership with Asian Americans Advancing Justice, also helped produce the first demographic profiles of their kind, which focused on Native Hawaiian and Pacific Islanders in the United States and in California, with the help of over 80 Native Hawaiian and Pacific Islander community leaders. The state of California already recognizes the importance of collecting disaggregated data. This bill would simply add additional categories to those being collected and reported. It also helps bring our state in closer alignment with categories utilized by the U.S. Census Bureau. While these categories represent only an incremental step for the institutions listed in the bill, the data represents vital information for small but fast-growing communities in this state. The disaggregated data we have been able to uncover reveals alarming disparities that highlight the need for more. For example, the age-adjusted death rate for Native Hawaiians and Pacific Islanders in 2012 was higher than all other racial groups except Blacks or African Americans. We also discovered that 30% of Tongans in California do not have health insurance, compared to only 17% for the aggregate Native Hawaiian and Pacific Islander category. This bill provides policymakers, researchers, and communities with a means to diagnose our challenges with greater precision while sending the message to these communities that all of us matter. Thank you.
Thank you. Anyone else in support? State your name and position.
Hi, Lin Hong Jung on behalf of the Southeast Asia Resource Action Center. We're one of the co-sponsors of the bill, and we're in support of this bill.
Kat New on behalf of another co-sponsor of the bill, the Asian and Pacific Islander American Health Forum, in support.
Andrew Medina of Asian Americans Advancing Justice California in strong support.
Rocio Gonzalez on behalf of the Having Our Say Coalition in strong support.
Autumn Ogden with the American Cancer Society Cancer Action Network in strong support.
Mr. Chairman, Manny Diaz, I'm representing the San Jose Evergreen Community College District in support. And also as an individual, as a former city councilman and state legislator from San Jose, I believe it's very important that decision makers really have good data. In San Jose, for instance, 20 years ago, our API community wasn't as large as it is today. I think it's imperative that you have this kind of information so you can make some good decisions.
Michelle Cabrera on behalf of SEIU California in strong support.
Jaime Ruiz Veloz with the Latino Coalition for a Healthy California in support.
Gina De Silva on behalf of the California Immigrant Policy Center and the Mexican American Legal Defense and Educational Fund in support.
Christina Avila on behalf of the Campaign for College Opportunity in very strong support.
Janice Yamaoka Luzak, Sacramento chapter of the Japanese American Citizens League in support.
May Lee with API's rise and definitely in support of 1726.
Yan Xiang with Southeast Asian Assistance Center in support.
Good afternoon. My name is Pham Se Turn, and I'm part of the Yumian community in support of this bill.
Laura Vu, Hmong Innovating Politics, we're in support.
Linda Ng, OCA, Asian Pacific American Advocates in support.
Sarah Lindner on behalf of the National Association of Social Workers in support.
Nora Lynn on behalf of the California Faculty Association in support.
Elaine Abele Mateo on behalf of Philippine National Day Association and East Bay Asian Youth Center in strong support.
Elizabeth Landsberg, Western Center on Law and Poverty in strong support.
Tam Ma with Health Access in strong support.
Michael Radigan on behalf of the Board of Supervisors, Santa Clara County in support.
Brian Ortiz on behalf of the American Civil Liberties Union of California in support.
Vincent Agbiani on behalf of the Asian Community Contractors Association, support. Thank you. Anyone else? Opposition? you can state your name and your position, and if we can be concise and try to stay about the same amount of time as the proponents, and then we'll ask those over here to the left to just state your name and position. Anyway, please proceed.
Thank you. Good afternoon. My name is Xin Guo, and I live in Elk Grove, and I work in Stockton as a professor in pharmacy. And as a healthcare professional for over 15 years, I'm gravely concerned about this bill. This bill will subcategorize Asians and link that with propensity of major diseases and then post the findings on the internet. And this will force Asians to reveal highly sensitive medical information that are vulnerable for serious abuse, such as higher health insurance premium and denial of employment. The federal law, GINA, and the state law, CalGINA, addresses these concerns and prohibit many kinds of acquisition and use of genetic information for decisions in healthcare, education, and employment. And as a healthcare educator, I'm also concerned that this bill will threaten Proposition 209, which prohibits the consideration of race in public education. This bill states that California community colleges, state university, University of California to use additional separate collective categories and other tabulation for specified Asian groups and Pacific Islander groups, and to take additional actions as specified above under certain circumstances. Now, if race is not allowed for consideration at higher education in California, then why does this bill designate public universities to collect such detailed information? Human medical error is the third leading cause of death in U.S., claiming 200 to 400,000 lives each year. To improve this situation, we need to recruit, educate, and license future healthcare providers purely based on merit and never on race. For the sake of future healthcare, we simply cannot afford to move away from Proposition 209. And a final note on medical error. Do we want our doctors to diagnose us by science-proven, FDA-approved tests, or do we want them to be biased by findings of this bill? Thank you for letting me speak.
Thank you. Anyone else?
Good afternoon, chairmen and members. My name is Yi Grizel. I'm a new immigrant and a first-generation American. I live in Roseville, California with my husband and 3 young children. And I'm very concerned about Assembly Bill 1726. It targets Asian Americans who make up only about 15% of the total population of California. If the state legislature is truly concerned about better understanding demographics to help all underprivileged groups, why are no other racial groups proposed to be subcategorized? For example, why no Latinos, Caucasians, or Middle Easterners who each immigrated from different countries that carries just as diverse a background, not subcategorized and included in this bill? This bill singles out only Asians. Furthermore, shouldn't we be using more relevant indicators such as household income, education attainment levels, and linguistic isolation, which are already serving to direct state resources, rather than attempting to subcategorize the Asian community? This bill completely ignores the differences among the individuals and the individual families within the Asian community. For example, not all Pacific Islanders, like or Vietnamese or Chinese, are either advantaged or disadvantaged. There is a mix within each. We need to look at the individual against relevant factors I mentioned to get a true picture of their circumstances. Let's be very thoughtful about how we direct our state's limited resources and provide assistance to those individuals who have legitimate needs based on individual circumstances, rather than based on a ill-advised attempt to subcategorize a single race. Thank you for the opportunity to speak before you.
Thank you. Anyone in opposition, if we can just state name and position. We'll start over here.
Palmer Kane from Santa Cruz, California. Mr. Chairman, committee, thank you for taking a moment to listen to what I have to say. Citizens have asked Assemblyman Banta why he put this bill forward.
Sir,
yes.
I asked name and position.
Oh, excuse me. Sorry.
Support or oppose?
Oppose.
Okay, thank you.
Thank you. May I continue?
No, we're going to move on. Just so from here on out, you just state your name and the position.
Very good.
Thank you.
Hi, my name is Wei Ping Li. I'm opposing this bill on behalf of the organization Silicon Valley Chinese Association.
Thank you.
Hi, my name is Jennifer Xie. I strongly oppose the bill. I'm from the Elgo Chinese Association.
Thank you.
Wendy Zhang from Flow Crow, strongly oppose.
My name is Chun Xia Zhang. I come from a Sematel Chinese community. I oppose this bill.
Hi, my name is Ying Chu.
Hi, my name is Zheng Yan Li.
My name is Bing Dam. We strongly oppose this bill. Thank you.
My name is Xin Wei Yang, Sacramento, Dongjiu, Vietnamese Chinese community.
Thank you.
Xin Wei Yang.
My name is Parker Yuan, and I live in Fosun. I strongly oppose. Thank you.
Qiang Wang, strongly oppose.
My name is Yiping Wu from Sacramento. I'm strongly opposed.
My name is Yi Fu Wu from Sacramento. I opposite AB 1726. Thank you.
Hi, my name is Hai Wang Chu, and I'm from Elk Grove. I strongly oppose this bill. Thank you.
Hi, I'm Li Yang from Elk Grove. I strongly oppose this bill. Thank you.
My name is Yin Su from Elk Grove. I have 3 kids, so I'm very strong oppose this bill. Thank you.
My name is Feng Yin Chen. I live in Elk Grove. I'm oppose. Thank you.
My name is Annie from Elk Grove. I don't like AB 1726.
I'm Yali Fu from Elk Grove. I'm opposed. Thank you.
My name is Yanhua Pen. I'm from Elk Grove. I'm strongly against this bill. Thank you.
My name is Olivia from Fremont, and I'm a student, and I oppose 1726.
My name is Joanne Den from Fremont community, and I oppose the bill.
Good afternoon. My name is Su Chen. I live in Sacramento. I strongly oppose this bill. Thanks.
Hi, good afternoon. My name is Wendy Shu. I'm from Elk Grove. I oppose this bill. Thank you.
Hey, my name is Anne Fang. I'm from Sacramento. I'm strongly oppose the bill.
I'm Irene Zhang from Sacramento. As a health analyst for the past 10 years with the state, I can say that I see there's no base of the findings about further categorizing the Asians into smaller groups. I'm strongly opposed this bill.
Hi, my name is Wendy Zhao. I'm from Elk Grove Chinese Association. I strongly oppose the bill. Thank you.
Good afternoon. My name is Connie. I strongly oppose this bill. Thank you.
Hi, my name is George Yang. I'm from Menlo Park, California. We have a similar bill, AB 176, that was vetoed by the governor last time. So I oppose this bill because this is essentially the same bill. And if this bill has some amendments as to not to use for racial profiling, I think that we might be able to pass. Thank you, sir.
Thank you. Seeing no other opposition, any questions? Yes, Senator Nguyen.
Assemblyman, what's the difference between this bill and the one last year?
Pardon? The main difference is that we don't have DMHC involved. So essentially, it's a very similar bill. We're collecting, some of the timelines are a little bit different as well as in terms of the implementation, but the core principle, the core concept is the same.
So why did the governor veto it then? And why would the governor, he vetoed it last year. Would he have any inclination to support it this year? Because I supported it last year. I want to make sure that, you already know that. It's just, I'm trying to understand what is our chance this year? Is it because of the department being removed, or?
First of all, thank you for your support last year. The Senate was unanimous in support for this bill last year, which I very much appreciate. The governor wrote a detailed veto message. He had some things in it that we have sought to address with the bill. One of the concerns was the timeline, so we sought to address that. The cost was a component we're seeking to address as well. But some of the other parts of his veto message we just simply didn't agree with. He said that in one place that this bill may lead to more data but not necessarily more wisdom. I take the exact opposite view. I think we talk about all the time in the legislature about having data-driven policy, evidence-based policy. This is exactly that data. This is exactly that evidence that could potentially drive policy. And so we've taken a process with the governor's office where we're seeking to educate more, answer questions. We've had multiple meetings essentially from the day after the veto until today. So like many bills, this is not the first time you'll see a bill that didn't quite make it the first time, but has been worked on and it comes back. That iterative process is a part of our legislative process. And so we're engaging in that today, and we're hopeful that he'll sign it this year.
And my last question is, last year I don't remember the opposition that we've seen today. Can you help maybe address the concerns that some of the members here who stated that why aren't other communities or subgroup? I think it's, in terms of Asian Americans, for me, Asian Americans, the subgroup actually makes sense. Although, the culture is similar but very different. Language is extremely different. Rin language is also different. Vietnamese we actually adopted our Rin language through the French. So we have an alphabet language and not the Chinese character like most of the Asian American communities do. I see the need for that, because when we in Orange County address Asian Americans, we tend to actually would talk first the Vietnamese Americans because they're higher concentration there. And so that's a different culture, different language. Then if we went down to different cities, it's different. Like Irvine, we have a larger Chinese American community. So I just want, it seems like I think there might be some misunderstanding here with some of the opposition, or I'm misunderstanding the bill.
I think it's the former. I think you understand the bill exactly as it's been written, Senator. And you can hear from the comments that there certainly is a misunderstanding, perhaps some misleading by other forces with the opposition. And here's one of them. A lot of the comments you heard started with the false premise that this is not happening now, that this would be the first time that this data would be collected. This data is being collected now. It's been collected for years. It's been collected by the federal government. It's been collected by the state government. These exact categories are being collected by certain departments in the state of California. We simply want to extend those additional categories to our higher education segments and to our health departments. You also heard some comments that this bill does something it absolutely does not do, that it prescribes a policy of some sort. It does no such thing with respect to what you do with the data. It simply says we want to collect the data and makes no prescription or comment whatsoever on what policy will follow. We heard some comments about Prop 209. That's a constitutional requirement in this state. A bill authored by Rob Bonta or any other legislator simply cannot change the Constitution of this state. And I heard comments. I met with the Silicon Valley Chinese Association, who you heard based on some of the comments is in opposition. And there was worry about quotas, affirmative action quotas, which has been unconstitutional based on the United States Supreme Court jurisprudence for some time now. So there's some fear. There's some concern, and I get that. And so that's why I met with that organization and any other organization that wants to meet with me so that we can do exactly what you've said. Let's start talking about the same thing. Let's talk about what this bill is, not what it's not. And I think you have captured exactly what this bill is about and the reasoning behind it, because the API community is not monolithic and has many differences within it, that it's important to say to all API communities that you should not be rendered invisible. You should not be concealed. You should be revealed. You should be visible. The data related to your community should be something that we can consider. What we do after that, we'll have a discussion and a debate about, and that will be a whole separate process. But collecting the data, I think, is appropriate. I think there's nothing to fear from data, and there's a lot to gain from it.
Thank you.
Thank you. Any other questions? Yes, Senator Roth.
Just one. This is a health committee, so I certainly understand the need for health-related data and health-related data in a very specific way, so this legislature and the state can begin to address specific health issues in communities where they arise. My question, since this is not an education committee, my question relates to the data call on the requester data from UC and the data call on the CSUs and the community colleges. And I guess my question is, why and how do you envision the data being used? I mean, data for data's sake is one thing, but obviously you have a bunch of folks who are fearful, either actual fear or perceived fear and concern. So I'm just curious, as if that's a fair question.
It's a great question, and let me give you a couple examples. We know from disaggregated data, and only because of disaggregated data, that hepatitis B occurs more frequently in the Chinese American community. We know that suicide rates are higher in the Korean American community. We know that for Korean Americans, Cambodian Americans, and Thai Americans, there's lower rates of health insurance coverage. When you know those things, you can take targeted intervention, you can do education, outreach, take prevention steps to help avoid all those challenges. I think most of us would agree that if we could bend those curves and move them in a different direction to prevent hepatitis B, to prevent suicide, to provide more health insurance coverage, that we would do so. So the data arms us with the ability to take those steps. If you don't have the disaggregated data, then those key kernels of information get hidden, and we never see them. So we want to reveal those pieces of information so that we can take those appropriate next steps.
Thank you. Okay, thank you. Seeing no other questions or comments from any of the members. Is there a motion? Moved by Senator Pan. We are at item 7. Item number 7, 1726 Bonta, due pass to appropriations. What would you like to close? Sorry.
Yes, thank you for your consideration. Thanks for your comments and your questions. At its core, this is a bill of inclusion. It says that no community should be left behind, and I respectfully ask for your aye vote.
Thank you. The chair is recommending an aye. Due pass to appropriations. Call the members.
Hernandez? Aye. Hernandez, aye. Nguyen? Aye. Nguyen, aye. Hall? Mitchell? Monning? Nielsen? Aye. Nielsen, aye. Pan? Aye. Pan, aye. Roth? Wolk?
Currently has 4. We have members absent. We'll place that bill on call.
Thank you.
Yep. Okay. Which one?
737.
There's number 19.
We're at item number 19, AB 2737, Bonta, non-provider healthcare districts.
Thank you, Mr. Chair, and I promise I will step down from this podium after I'm done with this bill. I know you've seen enough of me.
That's a promise.
It's a promise. AB 2737 is a district bill. It's a good government bill. It would place in statute a ratio regarding how much money Eden Township Healthcare District must spend on community health grants as opposed to administrative expenses. Back in 1948, Eden Healthcare District was originally established to serve the healthcare needs of a number of cities in the East Bay, and in doing so, it built a hospital, Eden Hospital. For a number of years, it owned and operated that hospital, but no longer. It doesn't operate a hospital, and it doesn't provide any direct health services to the public. It currently primarily serves as a landlord and grant-making entity whose real purpose should be providing grants to community nonprofits that provide healthcare services. Many of you may have seen the grand jury report that recently came out that was investigating Eden Healthcare District's practices. One of the striking findings that it had was that the healthcare district spends 88% of its resources managing its real estate holdings and only 12% on mission-related activities regarding provision of healthcare. For a healthcare district with a publicly elected body governing it, that is a problem. And this bill simply asks that they spend 80% on healthcare rather than 12%, and start providing healthcare to the community that the community deserves and that is part of its own mission statement. I thank you for your consideration. I respectfully ask for your aye vote. And with me, I have Nicolo DeLuca representing the City of San Leandro and the Mayor of San Leandro, Pauline Cutter.
Okay, thanks. Good afternoon, Chair Hernandez and members of the Senate Health Committee. My name is Pauline Cutter, and I am the Mayor of San Leandro, and we are the sponsor of AB 2737. I'm very grateful for this opportunity to talk to you about our top legislative priority for my city, San Leandro, and that is finding a solution to help address the financial sustainability of the San Leandro Hospital. The hospital is not only critical to the health and well-being of all of our residents, but it's also an economic driver for our region. And I want to highlight that this is a district-specific bill. The City of San Leandro and Alameda County have made considerable efforts to keep the hospital open, and it includes the unprecedented move of the City of San Leandro donated over $3 million out of our general fund budget to keep the hospital open. And in fact, today was the day we made our last payment of $1 million. That, along with the county, we've donated over $6 million to subsidize the hospital. And the basic foundation for the healthcare district is to provide healthcare services, and Eden Township no longer does that. They have were created in 1948, but they no longer operate a hospital. When a healthcare district isn't following that basic premise of providing healthcare, we need to set something in place to make sure that we protect the community's interest. AB 2737 puts those rules in place by prescribing a non-provider healthcare district, specifically Eden, spend at least 80% of its annual budget on community grants awarded to provide direct healthcare services and no more than 20% of its budget on administrative expenses. By prescribing this breakdown, at least through legislation, we can make sure that our public's receiving their money's worth. With that, I respectfully ask for your support of AB 2737, and thank you very much for your time today.
So Nicolo DeLuca here, also on behalf of the City of San Leandro. I just want to echo what the members said. It's a good government bill. It's a district bill. Here to answer any technical questions and respectfully ask for your support. Thank you.
Anyone else in support?
Greg Herner on behalf of Alameda Health System in support.
Thank you. Opposition?
Sit down.
Good afternoon, Dr. Hernandez and members of the committee. I'm Dion Aroner, and I'm here on behalf of Eden Healthcare District, and the district is opposed to this bill. While the bill does not specifically mention the healthcare district, it is the target. Before I get into the specifics of the bill, a little bit of local history might be helpful. Assemblyman Bonta brought a bill before the legislature last year, AB 72, which was gutted, and you just heard it. Spent a great deal of time on it this afternoon, but it was an original bill, and what originally it was supposed to do was to ask the voters to restart their tax increment, which they had terminated in 1987. That's because healthcare districts are the only special district right now that does not have the right to set a tax increment, which might have been an oversight, actually, when the special district legislation was done. The reason the district was asking for that permission was due to the pressure being brought upon it to give funds to San Leandro Hospital, which you just heard about, which is a county facility that is struggling to make ends meet. This bill before you does not resolve the financial difficulties of San Leandro Hospital. And more important, the language in this bill is so unclear and leaves the interpretation to the reader. It gives no assistance to whomever is supposed to enforce it. For example, when defining administrative overhead, does that include the mortgage payments, the management upkeep of the medical buildings, and the insurance on those buildings? How do those items get accounted for? The bill refers to spending 80% of a district's budget on community services. Is that the total budget of the district or the net revenue after cost for generating that revenue have been subtracted? Since this district does not have a tax increment, the revenues that are generated from the buildings that they own and manage is what creates the dollars that are available for the community. Lastly, the bill does not delineate who enforces and decides whether the district is in compliance with the provisions of the bill. Is it LAFCO? Is it the Department of Healthcare Services or some other agency? This bill, as it stands, does little to improve the performance of a healthcare district, let alone place into statute a well-thought-out reform. Most importantly, the future of this district is going to be resolved at the local LAFCO level. That has received a request, from the city of Hayward now to dissolve the healthcare district. I recommend that you let that process run its course instead of adopting a poorly written statute that has no enforcement mechanism. On behalf of the district, we ask for your no vote. Thank you.
Mr. Chair, members, Jean Hurst here today on behalf of the Association of California Healthcare Districts, also regrettably in opposition to AB 2737. We do appreciate the committee's fine work and sort of digging through what is a very detailed history of the scenarios in this district. We are concerned about the precedent-setting nature of the bill. We recognize that there are legitimate concerns about the operations of the district, but also the provision of healthcare in the community. However, we concur with the district that the local process is really where this dialogue needs to take place. As Ms. Aroner mentioned, the City of Hayward has initiated a conversation with the local LAFCO. We believe that this is the appropriate venue by which to have an open dialogue with representatives from the cities in the community, the county, and the stakeholders involved. We think that's the appropriate place to have this conversation. Should that process fail for whatever reason, certainly there might be an interest in the legislature weighing in, but at this point we believe that's premature before that local dialogue has taken place, and we would urge your no vote today.
Anyone else in opposition?
Christina Lockey with the California Special Districts Association in opposition.
Thank you. Questions, comments, any of the members? Seeing no questions and comments.
Chair?
Oh, yes, sorry.
So,
Senator Roth.
This sounds like a real estate holding company to me. I mean, why does the district continue to exist?
I mean, that's a great question. That's the question that Assemblymember Quirk's bill asks and provides a solution to in the form of dissolution. My bill, I think, takes a little bit more of a moderate approach by saying if you're going to exist, do what your own mission says you will do, which is provide grants and support for health care, not spin your wheels as a real estate holding company. It's not doing that, but this bill would provide it an opportunity to do it, and it would provide it some guidance on exactly how to do it and how much it should spend. No less an authority than the grand jury found that it was utterly failing in its mission, had no plans to change, my bill gives some guidance and, frankly, a little nudge to allow them to change in the right way that does right by the community members.
I'm typically a big supporter of local control and local option and local action, but I have to tell you that I believe I will be in support of this bill. I find it unusual to say, to be kind, that a healthcare district continues to exist apparently long after its mission has evaporated. So just a comment. Thank you, Mr. Chair.
Thank you.
Thank you, Senator Roth.
Any other comment? See no other comment. I've got a comment, maybe a question. So yes, my understanding that health districts are formed by the vote of the people, that they should have a mission to provide care to that community, albeit that this health district may have gone off track and is not doing it, it's becoming a real estate holding. I understand it came to Health Committee, but I believe that this is a governance issue. even though health is part of the conversation. And I posed the question, why didn't it go through governance and finance? But apparently it didn't. I don't know how that happens, because it's a governance issue. My concern, and like Senator Roth mentioned, that he believes in local control. I agree as well that because it was a vote of the people, I think the people should determine the outcome as opposed to the legislature determining their outcome. I think the people should have that, be part of that conversation. And because of that, even though it's not doing its mission, I'm just going to not vote. I'm taking a none position. Obviously, the members should vote the way they do, but I look at this purely from a governance structure, as opposed to, even though I know the health district isn't doing its job. So I'll be a none vote today. So any other questions or comments? So Sienna, would you like to close?
Yes, thank you for your comments. And just to Mr. Chair's comments, I think we were in local government in the Assembly. I know we didn't do it on this side, and I'm not sure why. I think there's some decisions being made that I wasn't a part of. But, I'm not entirely certain that the voters are aware that what was once a healthcare district with a hospital is now essentially a real estate holding company. I'm aware of it, and as a representative of the folks in that district, I think it's incumbent upon me to help provide a solution. This is more in the form of corrective action. It allows for change in the right direction if they're willing to do it. It's not punitive, and it provides some guideposts for goals that they can meet. I'm from local government. I am very deferential to local government as well, but sometimes there are multiple chances that are offered and not taken, and other steps need to be taken, so that's why I'm here.
Yeah, and I appreciate it, and this will be, do we have a motion? Motion by Senator Roth. Would you like to close?
I respectfully ask for your aye vote. Thank you.
Item number 19, AB 2737, do pass two appropriations. Call the members.
Hernandez. Nguyen. Nguyen I. Hall. Mitchell. Monning. Nielsen. Nielsen I. Pan. Roth. Roth I. Wolk.
Currently 3. We'll place that bill on call.
Thank you, Mr. Chair, colleagues, and staff. I'm stepping down and not coming back.
Thank you. I believe we have Assemblymember Waldron, who is next.